Good morning, Honorable Emeritus Chairperson Dr. M. L. Sankar sir, Dr. Achal Gulati sir, Dr. Jaiswal sir, and my colleagues. Today, this CCR is presented by Department of Pulmonary Medicine, and I'll give you brief introduction about the department. This department was established in January 2022, and presently there are two faculties. I am the professor and head of the department, and Dr. Sunil, he is with me as associate professor in the department. We are conducting interventional pulmonology, which includes flexible bronchoscopy and allied procedures like bronchoalveolar lavage, transbronchial needle aspiration, endobronchial biopsy, transbronchial lung biopsy, foreign body removal, and closure of BPF. There are some of the pictures of EBUS, which endobronchial ultrasound guided transbronchial needle aspiration, which we are conducting to diagnose the mediastinal lymphadenopathy pathology as well as the staging of the lung cancer. This is the way the needle goes under the ultrasound guided, and we take the biopsy from the lymph node which is adjacent to airways. Also, we are doing rigid bronchoscopy, thoracoscopy for the diagnostic as well as the therapeutic procedures for the pleural biopsy, for the pleural disease. Also, we are conducting lung FNAC and percutaneous biopsies, intercostal tube drainage and pigtail catheter insertion, and thoracocentesis. We have allergy lab where we are conducting skin prick test and immunotherapy for the allergic diseases. We have pulmonary function lab where we are doing spirometry, DLCO, 6 minutes walk test. We have future plans in our mind. First of all, our department is waiting for the approval from the DM Pulmonary Medicine, and once we are approved, we will be the first department of pulmonary medicine in state to start DM Pulmonary Medicine. We plan to start cold therapy, the cryotherapy for debulking of intraluminal tumor, for transbronchial lung biopsy from the interstitial lung diseases, and also for extraction of the foreign body. We are also planning to have organ plasma laser for control of intrabronchial bleeding and also for the debulking procedure, and electrocautery where we are also removing the obstruction, intraluminal obstruction, and also for the control of hemoptysis. We want to establish a level 1 sleep lab for patients of obstructive sleep apnea. We have EBUS, we are starting, once we get the cryobiopsy, we will start EBUS cryobiopsy for mediastinal lymph nodes. We want to upgrade of allergy lab for availability of CRD, component result diagnostic, where we can precisely diagnose the responsible allergen for precision treatment. We cold cryotherapy, bronchial cryotherapy is there is a probe, and with that probe we are releasing nitrogen dioxide, which freezes the tissue in the. So, periphery we are going through the channel of the bronchoscope, and through the periphery we are freezing the tissue and taking out it. Similarly, we can freeze the clot, we can remove the clot, we can remove the foreign body. Also, if there is intrabronchial obstruction, we can freeze that tissue that becomes devitalized, and then we will take out the tissue from the intraluminal bronchus. There are the few of the publications from the department faculties in international and national journals. They are the academic activity which we are conducting in the department, and they are some of the conferences where our faculty has participated as faculty. Now I'll invite our PG resident Dr. Prajwal Meheshwari to present the case of today. Thank you.
Good morning to all the dignitaries, respected faculties, and my colleagues. Myself, Dr. Prajwal Meheshwari, third year junior resident from Department of Respiratory Medicine. I will be presenting case of 34-year-old pregnant woman with dyspnea under the guidance of Dr. Suresh Kulwal sir and Dr. Sunil sir. I'll begin with patient particulars. A 34-year-old female with 26 plus 3 week of twin pregnancy by in vitro fertilization. Residents from Savai Madhopur, Rajasthan with socioeconomic status of lower middle class. Presented with chief complaints of dry cough since 7 days, fever since 5 days, dry cough since 7 days, fever since 5 days, and breathlessness since 3 days. Patient was relatively asymptomatic 7 days back when she developed cough, which was gradual in onset and progressive in nature, not associated with expectoration, hemoptysis, no postural diurnal variation were present. There were no aggravating and relieving factors. Patient had moderate grade intermediate fever since 5 days, associated with body ache, not associated with chills and rigor, burning micturition or night sweats, not associated with rash, and there were no aggravating or relieving factors. She had breathlessness since 3 days, which was progressive in nature. Dyspnea was graded as MMRC grade 1 initially, which progressed to MMRC grade 4 at the time of admission. There was no orthopnea, trepopnea, platypnea, paroxysmal nocturnal dyspnea, or diurnal variation. Patient underwent successful in vitro fertilization 26 plus 3 weeks before. Patient had no previous history of similar complaints, no previous history of diabetes mellitus, hypertension, coronary artery disease, or previous history of allergies, or any previous history of antitubercular therapy. Family history was non-contributory. She was married since 7 years with no children, vegetarian by diet. She was receiving adequate sleep and a good appetite. Bowel and bladder movements were normal and regular. There was no history of alcohol intake, smoking, or any substance abuse. Last menstrual period was 8th March 2025 with period of gestation of 26 plus 3 weeks. Previous menstrual history was regular and normal flow. Obstetric history was priming gravida with IVF conception. Married life since 7 years. On general physical examination, patient was conscious, cooperative, and oriented to time, place, and person. She was having breathlessness at rest. Temperature 38.4 degrees Celsius. She was tachycardic with 138 beats per minute, regular, no radial or radiofemoral delay. Blood pressure was normotensive, 128 by 80 mmHg, in measured from right arm in supine position at admission. She was tachypneic with respiratory rate of 38 per minute. Saturation at room air was 78%, and on 5-liter moist oxygen support, which was provided via face mask, was 95%. On examination, pallor was present, but there was no signs of clubbing, icterus, lymphadenopathy, cyanosis, or pedal edema. Upper respiratory tract examination was normal with nose in normal appearance, septum in midline, no deviation, no secretions of polyp, paranasal sinus were normal, no tenderness on palpation, oral cavity was on examination was normal. Lower respiratory system examination on inspection, the shape of the chest was elliptical and bilateral symmetrical. Trachea was centrally placed, apical impulse was not visible, chest expansion was bilaterally equal. Patient was having accessory muscles of respiration in use, no visible scar, sinus, or dilated vein on chest. On palpation, trachea was central in position, apex beat was palpable at the left fifth intercostal space inside the mid-clavicular line. Chest full movement bilateral equal. Hemithorax expansion was equal on both sides, vocal parameters normal and fell equally on both sides. There were no localized increase in temperature or tenderness. On percussion, impaired nodes were percussed in the region of inframammary, axillary, infraaxillary region, suprascapular, interscapular, and infrascapular region. And resonant nodes were percussed at the supraclavicular, direct clavicular, and infraclavicular region. On auscultation, normal intensity of breath sounds were present. Vesicular breath sounds were heard all over the areas bilaterally. Biphasic crackles were heard in the region of inframammary region, axillary region, infraaxillary region, suprascapular, interscapular, and infrascapular bilaterally. To summarize, a 34-year-old female with 26 plus 3 twin pregnancy with complaints of cough since 7 days, fever since 5 days, and dyspnea since 3 days. On physical examination, she was tachycardic, tachypneic, pallor, and maintaining saturation of 78% at room air and 95% at moist O2 support delivered via face masks at 5 liters per minute. On systemic examination, impaired note on percussion and biphasic crackles on auscultation present in bilateral lung field. A question to the audience members: based solely on clinical examination and history, what could be the possibilities? No. There was no history of animal therapy.
So physicians in the audience, MD medicine residents, come up with something. एक दो possibilities तो बताओ. MD medicine residents हैं क्या? Yeah, please stand up. Say some possibilities. कुछ तो बोलो यार. Come on. इनको माइक दो पीछे. Come on, somebody volunteer. At least 3 differential diagnoses. Non-medicine residents कोई बोलेगा? Put them to shame. So carry on.
Yes, sir. The differential diagnosis can be divided into infective causes and non-infective causes. In infective cause, it includes viral pneumonia, in which COVID-19, H1N1, influenza virus, cytomegalovirus. In bacterial infections, Streptococcus pneumoniae, Haemophilus influenza, Moraxella catarrhalis, Mycobacterium tuberculosis. Fungal infection includes pneumocystitis, Girovecca pneumoniae. In miscellaneous malaria, leptospirosis, scrub typhus, dengue, and fever. Non-infective causes includes diffuse parenchymal lung disease, in which non-specific interstitial pneumonia, organizing pneumonia, hypersensitivity pneumonitis, cardiogenic pulmonary edema, pulmonary thromboembolism, pulmonary alveolar proteinosis, and diffuse alveolar hemorrhage. Routine investigation done at the time of
amniotic fluid embolism नहीं रखोगे possible.
Amniotic fluid embolism occurs at the time of delivery, where there is a leak in the amniotic fluid and the amniotic fluid enters into maternal circulation, resulting in anaphylactic reaction. And it is not a true embolism.
So during the pregnancy only, during parturition only, that will be kept. Okay.
Yes, routine investigation done at the time of admission. On evaluating blood investigation, complete blood count was suggestive of hemoglobin of 8.3 gram per deciliter, with raised inflammatory markers of both ESR 83 mm per hour and CRP 40.9 milligram per liter, with other blood investigation values within normal limit.
So, आप physician हो ना, when you are reporting a low hemoglobin, you have to report the RBC indices also. Where are the indices? What was the MCV? Pregnant patient could be iron deficiency, could be B12, folic acid deficiency, MCV low, high, microcytic, macrocytic.
So patient was already on iron folate.
So where is the RBC indices? RBC indices तो दिखाओगे ना anemia के patient में?
Yes. Chest radiograph with abdominal shield was done after taking informed consent. Chest X-ray shown is an AP view chest X-ray taken in supine position, suggestive of bilateral homogeneous opacity present in bilateral lung field in all areas, suggestive of acute respiratory distress syndrome (ARDS). Cardiac workup was also done simultaneously with ECG, 2D echo, and cardiac enzyme, which were normal. Arterial blood gas at the time of admission was conducted at 5-liter oxygen support. The analysis suggestive of respiratory alkalosis with pH of 7.46, PCO2 of 28.7, and on calculating the PF ratio was 213, which was suggestive of ARDS. Provisional diagnosis is acute respiratory distress syndrome, query viral etiology, and IVF in pregnancy of 26 plus 3 weeks. Patient was taken on non-invasive NIV support in MICU. Patient was started on empirical IV antibiotics, injection piperacillin plus tazobactam 4.5 gram IV 8 hourly, tab azithromycin 500 mg per oral 24 hourly, along with antiviral tab oseltamivir 75 mg per oral 12 hourly. Injection hydrocortisone 50 mg IV 6 hourly was also been added, and nebulization with ipratropium bromide 500 microgram and levosalbutamol 1.25 mg was given 6 hourly along with the supportive treatment. Negative fluid balance was
maintained. Why the steroids? What rationale for the steroids?
So there are various trials in ARDS where beginning of corticosteroid at early stage provides decrease in mortality. Being a case of ARDS twin pregnancy, mortality risks are both high for maternal and fetal. So corticosteroids have been started and it reduces inflammation. On re-evaluation after 2 hours on NIV support, patient was experiencing fatigue and increasing respiratory distress. ABG was conducted 2 hours after NIV support, and on comparing the ABG parameters with previous ABG showed worsening of oxygenation with decrease in PF ratio from 213 to 194, and PCO2 values were increased from 28.7 to 48.2. Elective intubation was done and patient was taken on non-invasive mechanical ventilation support. For management of pregnancy, obstetrician opinion was been taken. I now welcome Dr. Urvashi Jainani from Department of Obst and Gynae to discuss management of pregnancy in this case. Thank you.
Good morning all. I am Urvashi Jainani. I'll be discussing about obstetric management today. So a 34-year-old female, primary gravida, 26 plus 3 weeks, twin pregnancy with ARDS were referred to us from pulmonary department. This was a IVF conceived pregnancy and also RH negative pregnancy. She had no complaints of pain abdomen, bleeding PV, leaking PV or discharge PV. Patient was intubated and on antibiotics. There was no significant medical history. Sir, on the same day she was intubated. Initially she was on oxygen, then the condition deteriorated. She was shifted to non-invasive ventilator.
Invasive ventilation.
Sorry?
Invasive ventilation.
Sir, she was on
and then shifted
yeah,
to
then
invasive.
on the same day after 2 hours, because the condition was deteriorating, she was shifted to invasive ventilation. History of present pregnancy: she was booked and immunized in private hospital outside Jaipur. She was on capsule progesterone 200 mg 12 hourly vaginally, injection lower molecular weight heparin 0.4 mg subcutaneously once daily. Iron, folic acid and calcium supplements was given.
So she was already on LMWH.
Yes, sir. Because this was a IVF conception, so and IVF was conceived outside. We didn't had any documentation, but she was already on progesterone and lower molecular weight heparin.
So is that standard of care for
Sir,
IVF
it is not
pregnancy?
standard of care. Usually when it is an IVF conception and if it is an embryo donor, then in most of the cases lower molecular weight heparin is advised, but it is not a compulsion for IVF pregnancy.
It's not the standard of care.
No,
it's
it is not.
obstetrician's
It depends.
choice.
It depends if the patient requires. If there is any
Requires it? What do you mean requires?
required, as in if there is a
This is just
antiphospholipid syndrome or if there is thrombophobia or anything, then it is required. Otherwise, it is not a standard for IVF conception.
What is thrombophobia? I haven't heard of that word.
Thrombophobia. Sorry, sir. Sorry. Sorry, sir.
Carry on, please. Carry on.
Nuchal translucency and nasal bone scan was done at 13 weeks. Normal with dichorionic diamniotic twin gestation. Prophylactic cervical circlage was done at 16 weeks of gestation. Anomaly scan was done at 19 weeks, which showed no gross congenital anomalies in both fetus. Previous blood and urine investigations were within normal limit, except she was having moderate anemia. On examination, per abdominal examination, uterus was 28 to 30 weeks, relaxed. Multiple fetal parts were felt. 2 separate fetal heart sounds were heard with handheld Doppler. First fetal heart sound was along the right spino-umbilical line, which was 130 beats per minute, and second fetal heart sound was on the left side above umbilicus, which was 144 beats per minute. On the day of reference, investigations were done. Hemoglobin was 8.3 gram per deciliter. Indirect MGUMST test was done, which was negative. At the same time, injection anti-D 300 microgram IM was given for antenatal prophylaxis. Ultrasonography fetal well-being was done, which was suggestive of selective fetal growth restriction of twin B. Fetus A was 26 weeks 2 days, cephalic. Amniotic fluid index was normal, placenta interior. Estimated fetal weight was 924 grams. Fetus B was 24 weeks 2 days, transverse. Amniotic fluid index was normal, placenta interior. Estimated fetal weight was 724 grams, which was fetal growth restriction. Injection dexamethasone was given for antenatal steroid cover, and vaginal swab was taken, which was polymicrobial growth. Further, obstetric management was risk and consequences were explained of poor fetal outcome to the relatives, and twice daily fetal monitoring and twice weekly ultrasonography was done. I would now request Dr. Prajwal to continue.
On further evaluation, investigation and their findings were reviewed. Throat swab for H1N1 and COVID RT-PCR were negative. Tropical fever panel was negative. Serum procalcitonin was 0.03 nanogram per ml. Endotracheal aspirate for Gram-Sten, aerobic culture, Cbnat, KOH mount, fungal culture were non-contributory. Blood and urine culture were sterile after 48 hours. Patient was monitored clinically and daily ABG monitoring was done. On comparison of ABG conducted, findings were suggestive of worsening of oxygenation with decrease in PF ratio, and ventilatory requirements were on increasing trend with increase in PEEP and FiO2 and respiratory rate. On day 5 of invasive mechanical ventilation support, the ventilatory requirements were persistently deteriorating with FiO2 of 65%, tidal volume 320 ml, respiratory rate of 28 per minute, and PEEP 12 cm water pressure. On repeat endotracheal aspirate culture, Acinetobacter baumannii complex was grown, which was sensitive to trimethoprim sulfamethoxazole only and intermediate sensitive to cefaperazone and sulfactam and colistin. Antibiotics were escalated to injection trimethoprim sulfamethoxazole 320 mg IV 8 hourly, injection meropenem 1 gram IV 8 hourly, injection sulfactam 3 gram IV 8 hourly, injection polymyxin B 7.5 lakh international unit IV 12 hourly. Nebulization with colistin with 2 million international units were done 8 hourly. Antibiotics were escalated on day 5, and after stepping up the antibiotics, patient condition was deteriorating with worsening of oxygenation of PF ratio less than 100 on ABG analysis, which is suggestive of severe ARDS. In view of severe ARDS, patient was planned for prone ventilation after taking informed consent. Obstetrician opinion was taken for this. I welcome Dr. Urvashi Jainani for the management.
On day 7, opinion was taken for prone ventilation in view of deteriorating lung condition. On the same day, ultrasonography was done, which suggested severe oligohydramnios in both fetus. Fetus A was 26 weeks 2 days. Cephalic amniotic fluid index was less than 1. Estimated fetal weight was 1134 grams. Fetal B was 24 weeks 5 days. Transverse amniotic fluid index was less than 1 and estimated fetal weight was 764 grams. Option of termination of pregnancy was offered after multidisciplinary discussion because fetal weight was more than 1 kg and also there were severe oligohydramnios and selective FGR and deteriorating lung conditions of the patient. After detailed counseling, attendants opted for continuation of pregnancy. Risk and benefits of proning were explained to the relatives. Fetal monitoring after that was done twice daily and ultrasonography every alternate day. I would like to welcome Dr. Ivneet Kaur from Critical Care.
Thank you for inviting. I am Dr. Ivneet from Department of Critical Care and I shall be taking forward this case. In our case, the ABG was indicated of severe ARDS with PaO2 FiO2 ratio of 64.9 suggesting refractory hypoxemia. She was on mechanical ventilation on lung protective strategy of 6 ml per kg tidal volume. PEEP was optimized according to recruitment and driving pressures, respiratory rate of 30 with high FiO2 requirement. The indications of proning in this case was severe ARDS with PaO2 FiO2 of less than 100, PEEP requirement more than 5 and FiO2 more than 0.6. Refractory hypoxemia with PaO2 less than 60 despite high PEEP, lung protective ventilation and neuromuscular blockage, high plateau pressure and poor compliance of the lungs. The challenges of prone ventilation in this case was already reduced functional residual capacity in pregnant patients due to gravid uterus, increased risk of aspiration, difficulty in positioning the abdomen safely, chances of breast compression in pregnancy, difficulty in continuous fetal monitoring, risk of uteroplacental hypoperfusion and risk of preterm contractions. So, we continued with sedation and paralysis for proning with a combination of opioid and neuromuscular blockade to maintain a Richmond agitation sedation score of -4 to -5, which corresponds to deep sedation to unarousable state. Our goal was to offload the uterus and breast and avoid the vena cava compression. So, we obtained high-risk informed consent from the family for proning. Total 3 sessions of proning was done for 16 hours, followed by supining the patient. It was done on alternate day in 6 days. According to a case report published in 2021 in Taiwanese Journal, the prone position in pregnant patients provide optimal relief of umbilical artery compression and this trial showed no difference in complications between the pregnant patients and the other group. According to other trial published in 2023, the ProSaver trial showed that in moderate to severe ARDS, early pruning extending up to 16 hours per day provide 28-day and 90-day survival benefit. So for the technique, we place 2 bolsters, one under the chest and breast and one under the pelvis and the upper pelvis to support the abdomen and abdomen to be freely hanging. We created a free belly space for abdomen to be freely hanging. Head was turned to one side, which was alternate every 2 hours with thighs slightly abducted. We maintained a 10 to 15 degrees left lateral tilt with wedge under the right side to prevent the aortocaval compression, and breast was supported with soft padding with continuous fetal monitoring. So the ABG on successive pruning sessions improved. Before first session of pruning, the FiO2 requirement was 85% with PaO2 FiO2 requirement of 64.9, and after the third session of pruning, the FiO2 requirement decreased to 40% with PaO2 FiO2 requirement increased to more than 150. It is 189. So for further management, I would request Dr. Prajwal to continue the case.
After 3 cycles of pruning, the ventilator requirements improved, but the patient was having on and off episodes of fever. Blood, urine and endotracheal aspirate were again sent for culture and sensitivity. Chest radiograph was repeated. The bilateral lung shadows were compared with previous chest X-ray were improved, but a new opacity in right upper zone was detected. On comparing the blood investigation findings suggestive of fall in leukocyte count from 17.8 thousand to 8,800, there were decreasing platelets from 2,58,000 to 1,59,000, and also fall in inflammatory markers from 61 to 24 CRP and ESR from 92 to 75. On repeat, endotracheal aspirate blood and urine culture were sterile after 48 hours. For evaluation of right upper zone opacity, bronchoscopy was conducted, in which the bowel fluid analysis, the gram strain was no pathogenic organism were detected, aerobic culture and sensitivity sterile after 72 hours, CBNAR for tuberculosis, target was detected which was rifampicin sensitive, QH mount for fungus was negative, galactomannan for aspergillus was also negative. Revised diagnosis was severe ARDS which is resolving, pulmonary tuberculosis, IVF, twin pregnancy. Antitubercular treatment ATT was started according to patient's weight 53 kg, isoniazid 300 mg, rifampicin 600 mg, pyrazinamide 1500 mg, ethambutol 1000 mg once daily in the morning was started after consultation with obstetrician. TAP pyridoxine 20 mg 24 hourly was also started. On antitubercular therapy, she started improving and became afebrile. Her ventilator requirements were improved. FiO2 requirement came down to 35% with PEEP 7, respiratory rate 18 per minute and tidal volume 320 ml. Patient was maintaining 97% saturation and other vitals were also within normal limit. Patient sedation was discontinued. Patient was conscious and oriented to time, place and person, but patient was unable to move her 4 limbs and was having fatigue on CPAP and pressure support mode of ventilation. Patient was unable to move her 4 limbs and was having fatigue on CPAP pressure support mode of ventilation. As patient was having difficulty to wean off, requiring prolonged ventilatory support, so tracheostomy was considered. Nerve conduction study was performed which showed sensory motor axonal polyneuropathy involving 4 limbs. This was critical illness neuromyopathy leading to difficulty in weaning her off from ventilator. Other causes of IC acquired weaknesses were ruled out. For management of CNM, Department of Physiotherapy opinion was taken. On comparison the consecutive ABG, the ABG analysis on day 20 showing improvement in oxygenation with increase in PF ratio from 189 to 343. I welcome Dr. Saniya Rahman from Department of Physiotherapy for management of CINM.
Good morning everyone. So the clinical context and diagnosis of the patient was status prolonged ICU admission, severe ARDS and pulmonary TB, required invasive mechanical ventilation, developed significant ICU acquired weakness ICU-AW and presented with profound bilateral motor deficits in all the 4 limbs. Our goal was to implement a phase-safe and pregnancy-appropriate rehabilitation program to reverse the ICUAW, to prevent any secondary complications, to restore the functional independence in bed mobility, transfers, and ambulation. All the physiotherapy assessment for the chest and for the limb was completed to understand to the patient's specific needs. Based on what was found, a tailored treatment plan was created and implemented. These were the techniques that was implemented on the patient: neurophysiological facilitation of respiration techniques, segmental facilitation techniques, rib springing, manual vibrations, box breathing, ACBTs, and thoracic expansion incentive spirometry were done. Yes, sir. Okay. So these were the improvements on 10 to 12-day intensive chest physiotherapy regimen. The following objective improvements were found: percussion sound from dullness to resonant signs bilaterally, vocal formatives from increased to normalized vibration, respiratory rate from tachypnea to steady, breathing pattern from rapid shallow to controlled and deep rhythm. These were the limb physiotherapy management. Initially the patient was totally passive, so the passive range of motion exercises, positioning was crucial to prevent the foot drop, shoulder subluxation, and finger flexor tightness. Facility techniques for roots approach, active assisted range of motions when the patient was active assisted, functional bed mobilities, sitting balance, edge of the bed, and when the patient was totally active, active range of motion exercises were done. Functional strengthening, advanced sitting balance, and supported standing and ambulation were done on the patients. Now I will welcome Dr. Prajwal, sir.
Patient was taken on portable PiPAP support AutoPAP, which was connected to a tracheostomy tube. She was tolerating to AutoPAP support very well. She was shifted to ward and continued with AutoPAP support. Her physiotherapy, rice tube feeding, antitubercular therapy, and other supportive treatment were continued in ward. Her critical illness neuropathy started to improve after day 7, shifting to ward. On day 10 of shifting to ward, she complained of leaking per vaginally, so obstetrician opinion was taken.
On follow-up, fetal monitoring was done by NST twice daily, and ultrasonography fetal well-being with Doppler was done every alternate day. On day 35 of admission, patient complained of per vaginal leak. Her upper abdominally uterus was 32 weeks relaxed, multiple fetal parts were felt. First fetal heart sound was along right spino-umbilical line, and second fetal heart sound on the left side above umbilicus. On post-speculum examination, leak was present, LICA was clear, and cervical stitch was removed. Decision for preterm cesarean section was taken in view of primi gravida, DCDA twin, IVF pregnancy with fetal growth restriction, and preterm pre-labor rupture of membrane, after discussing with multidisciplinary team and relatives. Female child of 1 kg and male child of 1.4 kg were born. Both were shifted to NICU. Patient withstood the procedure well. Injection anti-T 300 microgram IF was given because of rhesus positive status of both babies. Now I would like to welcome Dr. Kanika.
Very good morning to all. Very preterm twins, 31 weeker. Twin 1 was female with weight of 1 kilo. Twin 2 male with weight of 1.4 kilo was delivered via LSCS under steroid cover. The key neonatal problems were both the babies had low birth weight, and twin 1 had mild respiratory distress, had required non-invasive ventilatory support on day 1, and by day 2 was weaned off to humidified nasal flow cannula, and by day 3 and by day 5 was weaned to room air. The third issue was maternal endotracheal aspirate was positive for Acinetobacter, so we had to start empirical antibiotic with meropenem. Both the babies were evaluated for congenital TB. We had sent blood culture which came out to be sterile. Sepsis screen was negative. Chest x-ray, this is the chest x-ray. It had no infiltrates, no hilar lymphadenopathy. Gastric aspirate for AFP and CBNAT was sent, which was also negative. In abdominal ultrasound, there was no hepatomegaly, no granuloma, and so we had after ruling out congenital TB, we gave the BCG vaccination. Before shifting the babies to mother side, we had started with isoniazid prophylaxis that is 10 mg per kg per day along with pyridoxine. The plan was to give it for 6 months prophylactically. There was progressive weight gain and the babies were shifted on day 23 of life. The total duration of hospital stay was 1 month and the discharge weights were for the twin 1 was 1.6 kilo and for twin 2 1.9 kilo. We had encouraged breastfeeding as mother was on ATT and babies were on prophylaxis. The parents were advised for follow-up for every 4 to 6 weeks so that we could see the growth pattern. Thank you.
Post lower segment cesarean section, patient was shifted back to ward and continued on auto-PAP support. On post-operative day 3 of lower segment cesarean section, TP's trial was given in ward under close supervision and she tolerated TP's trial for 3 hours without any respiratory distress. Auto-PAP support was given intermittently during the course of weaning and after 3 days she was able to be weaned off from auto-PAP support. ABG was conducted at room air with a PF ratio calculating of 421. It was planned for decannulation on day 42 of admission. On post-operative day 8 of lower segment cesarean section, she was discharged in a stable condition and at the time of discharge she started walking on her feet. Recently she visited Pulmonary Medicine OPD on follow-up. She is doing well with no active respiratory distress and her both babies are also doing well. On follow-up, chest X-ray after 2 months of ATT, the right upper zone opacity is now showing small fibrotic residual lesion present which was improved when compared to previous chest X-ray. I welcome Dr. Sunil Kumar Sir, Associate Professor of Department of Pulmonary Medicine.
Good morning. We are continuing with the discussion of ARDS. As we all know, this is the previous definition of ARDS. The Berlin definition comes in 2012. Basically depends on the bilateral opacity on chest radiograph or CT, which are not fully explained by cardiac failure or fluid overload, and acute onset of illness within 1 week of non-insult. And 3 categories of ARDS were divided by the P based on P upon F ratio. And this require the requirement for invasive mechanical ventilation or NIV, and P greater than equal to 5 centimeter S2. But a new definition come in, a new global definition of ARDS in 2023. Intubation is not required. Patient on HFNC on requiring greater than equal to 30 liter per minute oxygen can have ARDS. And by this, according to new definition, ABG, if in resource limited setting, if ABG is not available, if patient saturation is less than equal to 97%, if we calculate SpO2 upon FiO2 ratio, if comes less than equal to 315, that can also consider as a ARDS. And bilateral opacities, which was previously considered on chest X or CT, but ultrasound has also been added. In ICU, if we do the ultrasound, we find the bilateral opacity that can also be considered. And this definition is very helpful in resource limited setting where respiratory support devices are not available or PEEP is not available and where the ABG are not performed. So ARDS in pregnancy, mostly viral infections, sepsis and massive blood transfusion are the commonest cause of ARDS during pregnancy. Maternal hypoxemia and hypercapnia leads to significant risk for both mother and fetus. For ventilation strategy in ARDS in pregnancy, usually lung protective ventilation strategy as for non-pregnant women is followed in pregnancy also. Low tidal volume 6 ml per kilogram protected body weight and plateau pressure limited to 30 centimeters S2 and respiratory rate up to 35 breaths per minute are usually should be considered in pregnancy, those who require the invasive mechanical ventilation. If there is a severe ARDS with refractory hypoxemia, so prone ventilation can be considered, and veno-venous ECMO can be a safe alternative in pregnant women with refractory hypoxemia and severe ARDS. By this veno-venous ECMO, we can have a time to prolong the age of fetus to a viable age and can prolong the pregnancy also. So in delivery, the decision to delivery and the mode of delivery always should be a multidisciplinary decision. Tuberculosis in pregnancy is a serious condition that can also lead to premature birth, low birth weight and complications for both mother and baby. Prompt diagnosis and treatment with anti-TB drugs are crucial as the drugs are safe in pregnancy. The risk of a premature or underweight baby is higher. The baby can also born with congenital TB or suffer from other issues if born to an untreated mother. Although the risk of congenital TB is also very rare, as mycobacterium tuberculosis bacilli does not cross the placenta. So viral infection is a commonest cause of ARDS in pregnancy, which may be fatal for mother and child both. If patient is not responding to initial therapy, always search for another associated reason. Multidisciplinary approach saves the patient. When treating the patient, the drugs are advised looking to the mind the risk and benefit ratio, keeping in mind to save the both mother and child. Anti-tubercular drugs can be safely prescribed in pregnancy. Patient relatives should be kept informed at every stage. We have take this out.
मेरी पत्नी को फेफड़ों में निमोनिया था और हालत बहुत ज़्यादा गंभीर थी, साथ में ट्विंस प्रेगनेंसी भी थी। हमने महात्मा गांधी अस्पताल के पुलमोनरी मेडिसिन विभाग में कार्यरत सह आचार्य डॉक्टर सुनील कुमार सर के अंडर में भर्ती कराया। मरीज को आईसीयू में रखा गया था और वेंटिलेटर लग गया था। वहाँ पर डॉक्टर सुनील कुमार सर और क्रिटिकल केयर मेडिसिन के डॉक्टर आशीष जैन सर एवं प्रसूति रोग विभाग के डॉक्टर स्वाति मैम और बाकी सभी डॉक्टरों ने मिलकर हमारे मरीज का इलाज किया। अभी मेरी पत्नी और दोनों बच्चे पूर्ण रूप से सही है, स्वस्थ है। हम महात्मा गांधी अस्पताल और सभी डॉक्टरों के आभारी है। मेरी पत्नी को फेफड़ों में निमोनिया।
So I am very thankful so much to MGUMST management, Emeritus Chairperson Sir MGUMST and Chairperson VC Sir and Dr. Hemal Malhotra Sir. I am thankful to Department of Respiratory Medicine, thankful to Department of Obst and Gynecology, Department of Critical Care Medicine, Department of Neonatology, Physiotherapy, Department of Microbiology, nursing officer and other nursing staff members, and most important thankful to the patient and her family.